Stanford University.
Welcome to our symposium on screening for women's cancer. My name is Jonathan Barrick. I'm a gynecologic oncologist, and I'm a professor of obstetrics and gynecology here at Stanford and the Stanford Cancer Center. I'm going to make a few brief remarks about screening for gynecologic cancers, and then I'm going to introduce my fine colleagues who are experts in breast cancer. Dr. Carlson and Dr. Akita, who are going to give you presentations on the diagnosis and screening of breast cancer. And we're going to try to leave plenty of time for questions. You'll notice that there are a couple of microphones on either side, so when we do get to that point, you can come up and ask your questions, and we'll be sure that we try to provide a good answer. As you know, there's been an enormous amount of controversy recently about particularly breast cancer screening and some of the new recommendations that have been promulgated. Most recently also there were some new guidelines for screening for cervical cancer, Pap testing. And they're less controversial, but nonetheless still raised a lot of concerns because it was a change. And I want to give you an idea of what those changes are, and so that we have a chance to discuss them. In gynecologic cancers, there really are, first of all, cervical cancer, for which there is an obvious screening tool. There are uterine cancers, most of which are endometrial cancers, and in general, there is not a screening tool that we routinely employ for that. And got it working okay? Great. And for ovarian cancer, we still don't have a good screening test. I'm going to explain a little bit why. First of all, what are the requirements for a good screening test? Well, it has to be simple, something that people can do easily. It has to be safe, something that doesn't expose you to too much radiation or something that would be a dangerous technique. And it has to be cost effective. That is, it has to be done in such a way that would be easy to administer to a large population of people in a manner where it makes sense to do so, that you get, so to speak, the bang for the buck, that you invest a lot of money in doing that, but it actually does allow you to detect cancers early, or preferably in a pre-malignant condition, such as in cervical cancer. We have the paradigm of the cervix, in most cases, having a pre-malignant condition, a dysplasia of the cervix that you can detect on a Pap smear. You can treat that before it becomes cancer. And then the critical thing is, can that screening test actually reduce the mortality of the disease? And that's a theme that you're going to hear my colleagues talk about as they talk about breast cancer screening. That is, if you can do a lot of tests and you can detect certain cancers early, but does that really impact the outcome? Does it impact the death rate from the disease? Does it reduce mortality? And that's a very important issue, because if you were to detect a lot of cancers, but they were in advanced stage, and it didn't change the mortality, then it wouldn't be a valuable screening tool. That's kind of where we are, by the way, with ovarian cancer screening right now. So we're going to cover, as I said, these four cancers very briefly. What are the cases currently of breast cancer in the United States? There are over 190,000 invasive cancers and over 40,000 deaths. So a lifetime risk is considered to be over 12%. Of ovarian cancer, there are over 21,000 cases and 14,000 deaths, and the lifetime risk is about 1.4%. Notice also that the only a smaller proportion, about 10 or 15% of ovarian cancers, are considered to be associated with mutations that you can inherit, so-called germline mutations, such as BRCA1 and BRCA2. In breast cancer, it's equally that case, although there are family clusters of other types of hereditary syndromes that predispose to breast cancer. Speaking of ovarian cancer first, the idea is to do a test when there may be preclinical disease or pre-malignant change before it gets to the point where it metastasizes, either a pre-malignant condition or a stage 1 disease. The problem is, at this point, using combinations of blood markers such as CA-125 and transvaginal ultrasound, which is the most common screening type of imaging test, they're neither sensitive nor specific enough to be able to make an impact in terms of screening. So we currently do not recommend using those tests in the general population. There are two very large studies that have been ongoing, one that's completed about a year ago and one that just fully accrued a few months ago. So it'll be a few more years as we follow in those randomized trials to determine whether or not these screening tools done over a period of time, so-called serial CA-125s, actually show that you can detect ovarian cancer early. But currently, based on the data we have now, we don't recommend population-based screening in ovarian cancer. It's only been recently that we've probably shown that there are some dysplastic lesions in the fallopian tube and on the surface of the ovary, which may in fact be the very earliest forms of ovarian cancer or of fallopian tube cancer, which can develop into an invasive tumor. The problem is that, unlike with mammography, as you'll hear, the current screening tests don't detect this at a very, very small level early enough to be able to detect it before it metastasizes. And that's why about 70 to 80% of women who present with ovarian cancer do so with advanced stage disease. The idea would be to somehow take this large percentage of women with advanced stage disease and detect it down here when the survival rates are superb. They're in the 90+% range compared to the 10 to 20% range with advanced stage. That's the dream and that's the hope. And there are a number of techniques that are currently being investigated, including here at Stanford, in terms of early detection, both radiologic techniques and blood markers, that may ultimately prove to be useful for screening, but we're not there yet. So, as I pointed out, no data to support routine use of these tests in ovarian cancer. And similarly, in uterine cancer, we don't really do screening for uterine cancer. Now, one of the reasons we don't is that there's not a big need to do so, because about 99% of the time when a woman develops a uterine cancer, she develops abnormal bleeding, and so this can lead directly to a biopsy as opposed to doing, say, a blood test or an ultrasound. There are certain circumstances and certain populations of women that are at very high risk where we do ultrasounds even in the absence of vaginal bleeding, in order to look for pre-malignant or early malignant lesions, but that's a very small subset of the overall population. So in general, we don't do screening for uterine cancer. The Pap smear, which, as you all know, is used routinely for cervical cancer detection, is not a reliable way to screen for uterine cancer, just as it's not a reliable way to screen for ovarian cancer or fallopian tube cancer. And that's because the cells up inside the uterus simply don't shed regularly all the way down to the cervix, where they can be picked up by a pap smear. So, moving to cervical cancer and a little bit of controversy, currently, in addition to the regular cytology test, the pap smear, we're now using more and more HPV testing. Virtually all cervical cancers and all precancers of the cervix are associated with HPV, human papillomavirus infections. And so you can detect that, and there are some of these viruses which we call oncogenic, which are more likely to predispose to cervical cancer. And in doing that, you can predict whether or not somebody is more likely to have a condition that might become cancer. Well, there are new guidelines, and I'm going to run through those in just a second. But before I do, I would at least like to point out that for gynecologic cancer, probably as important as anything are the preventative strategies other than screening tools. For ovarian cancer, we know that taking the birth control pill actually can reduce the risk of ovarian cancer. Women who've taken the birth control pill for 5 years or longer, even if it's been discontinuous, have about a 50% reduction in the development of ovarian cancer. And for a disease that is as difficult to detect early and as fatal as this illness, that's a very, very important observation. And it turns out that having children, having babies, pregnancies, will in fact reduce the risk of ovarian cancer. So a woman, for example, who has 2 children and has used the birth control pill for 5 years or longer for family planning, maybe the kids are exactly 5 years apart, in fact have a risk reduction of about 0.7, which means a 70% reduction in developing ovarian cancer. Pretty impressive, again, considering we don't have any good means of early detection. In women who are at very high risk, such as those who have very strong family histories of breast and ovarian cancer and are found to have germline mutations with the BRCA1 and 2 mutations, we perform prophylactic surgery to remove ovaries and fallopian tubes, so-called risk-reducing bilateral salpingo-oophorectomies. In endometrial cancer, we know that obesity is a major contributor to this, and so weight reduction, weight control, minimal use of exogenous hormones in the peri- and postmenopausal era, and exercise all reduce the risk of endometrial cancer. And in addition to routine screening, avoiding smoking, which is a very strong cofactor for the development of cervical cancer, STD protection, because we know barrier contraceptives can reduce the risk of the transmission of oncogenic viruses and subsequent development of pre-invasive disease. And now the use of the HPV vaccine, which at least protects against 70% of the oncogenic viruses, so-called HPV 16 and 18. So we now recommend that. What are the changes in screening for cervical cancer? The new guidelines, which, as I said, were a bit controversial, but not nearly as controversial as the breast cancer guidelines. The cervical cancer guidelines are now that we recommend starting at age 21. It used to say starting at the time when someone becomes sexually active, whether that's 15 or 16. The problem was that was leading to a huge amount of over-treatment of very young women. And it turns out that most of the cervical cancer in that age group is exceedingly rare. And it turns out that most of those lesions are reversible. They're low-grade dysplasias associated with the HPV infection, and they're quite reversible. So the new recommendation is to start at age 21 and then go every 2 years, as opposed to every year. And this was based on a cost analysis type of evaluation. This is a bit controversial. There are some people who feel that it ought to be more frequent than that, but most people actually have accepted that. I should point out that even though recommendations are for Pap testing have increased in the interval from an annual to every second or third year, as it is for over 30 in women who've had 3 normal tests and don't have significant HPV findings, that we still recommend annual physical exams and gynecologic exams because there are other things that one detects in those examinations beyond early cervical dysplasias. The other recommendation now is that after 3 normal tests that one can go every 3 years, that if one has had a hysterectomy for benign disease, really no Pap smears are necessary because you're not going to detect any significant lesions. And now the recommendation is to discontinue screening in the very postmenopausal patients once they've gotten past the point where they've had normal screens for a number of years. So these are much less controversial, and when we get to the time when we're doing some questions and answers, we can talk a bit about that if you have questions. As I said, I think most people have come to accept this in the context that as long as people are getting screened, this works. I'll leave the podium with at least one other thought, though. The problem we still have in this country is that we don't screen everybody. We have about 11,000 new cases of cervical cancer and over, well, almost 4,000 deaths from cervical cancer in this country alone. Now, compared to some of the other cancers, it's not a huge number, but obviously if you're one of those people or if that's one of your loved ones, it's one way too many. The problem is that upwards of 2/3 of the women who are dying from cervical cancer have not been screened in the past 5 years. And more than half of them have never been screened at all. So the problem we still have with cervical cancer is not detecting the cancer in the women who are being screened using this type of paradigm. The problem is that we're not screening all of our women, which is another issue, as you know. We've got a social issue and a public health issue that's very, very important that we confront in our society. Thank you very much. So while we're getting our expert to change the slides, I'd like to introduce my good friend and colleague, Dr. Robert Carlson, who's a professor of medicine and medical oncology, who is considered an international expert in breast cancer. And he's going to start off the discussion about breast cancer and give you kind of a general overview before we talk about some of the specifics of mammography. Thank you very much, Bob.
Thank you. So I'm going to follow up that introduction with the discussion about some more about the epidemiology of breast cancer in the U.S., risk factors for breast cancer, discuss very briefly issues of prevention, and then start a discussion of issues of screening as it relates to breast cancer. So breast cancer in the United States, huge problem, 194,000 new cases in the United States per year and over 40,000 deaths. Those of you who are CPAs in the audience will notice that my numbers are slightly different than Dr. Barrick's, and that's because I'm including about the 1% of breast cancers that happen in men. Men do get breast cancer, although it's just much, much less common. This slide shows the age-adjusted cancer incidence rates among U.S. Females, starting to the left in 1975 and to the right up to the year 2005. And as you can see in the pink line that's at the top, breast cancer is by far the most common of the serious malignancies facing U.S. women. You can also see that the incidence of breast cancer waxes and wanes from year to year. There's a suggestion that over the last few years that there's a substantial decline in breast cancer in the United States, and that's probably because of the decrease in the use of postmenopausal hormone replacement therapy. This shows the corresponding data for deaths from breast cancer, again, age-adjusted women in the United States. Breast cancer here, again, is in the pink, and as you can see, starting in about 1990 or so, there's been a relatively steady decline in deaths from breast cancer. The red line shows the rapid increase in deaths from lung cancer among U.S. women that started shortly after World War II, and that's almost entirely related to tobacco use. And so if you're a woman and you're here today because you're concerned about breast cancer and you smoke, you're at the wrong talk. This puts the two together. From 1975 through 2003, the yellow bars are relating to breast cancer incidence, and as you can see, a general trend upwards over that time period. And the blue bars at the bottom are deaths from breast cancer, and as you can see, the death rates from breast cancer are declining in the United States gradually, but consistently, despite the relatively stable or increasing incidence of breast cancer. So we're doing a better job. Some of this is almost certainly attributable to screening, and some of this is almost certainly attributable to more effective therapy. In the San Francisco Bay Area, we should be especially concerned about breast cancer, and that's demonstrated here. What we see are breast cancer incidence rates for the years 2000 to 2003 by major geographic areas in the United States. And as you can see, San Francisco has the second highest incidence of breast cancer of any of the major metropolitan areas in the United States. A huge local health problem for us. We can also identify with some confidence women who are at increased risk for the development of breast cancer. The strongest risk factor for breast cancer is being female. Increasing age is related to breast cancer development. Breast cancer under the age of 25 is very rare. Over the age of 25, there's a relatively linear increase in risk for developing breast cancer up to about age 80 or so, and then it starts to decline. There are genetic mutations, especially the BRCA1 and BRCA2 breast cancer gene mutations that, if present, greatly increase a woman's risk of developing future breast cancer. And with many of the specific mutations, those risks can be well over 50% lifetime risk. Positive family history, the closer the genetic relative, the younger they were, especially if their breast cancers are bilateral, is a risk factor for developing breast cancer. There are certain types of benign breast disease, especially the hyperplasias, the atypical hyperplasias, that increase risk for future breast cancer. Early age at first menstrual period is a risk factor for the development of breast cancer. Older age at first live birth is a risk factor for developing breast cancer. Older age in this context is over the age of about 25. Late menopause is a risk factor for breast cancer. Having had one breast cancer increases a woman's risk of developing a cancer in the opposite breast. And women who have had radiation therapy to their chest, especially as is given for Hodgkin's disease, between the ages of about 10 and 30 years of age, have an over 50% lifetime risk of developing breast cancer. There are also a series of minor risk factors, race or ethnicity. High socioeconomic status increases risk for breast cancer. Lots of education does. Being tall does. Being obese does. Taking hormone replacement, having a sedentary lifestyle, and drinking more than half a glass of wine, half a beer, or half a shot of alcohol a day also measurably increases breast cancer risk. And alcohol consumption is linear. So if you drink 2 glasses a day, it's twice as bad as if you drink 1 glass a day. It's 4 times as bad as if you drink half a glass of wine a day on average. But the most important issue about risk factors are which ones of them are modifiable. Which ones of these can we impact to change a given woman's risk for future breast cancer? Age at first birth, alcohol, socioeconomic status, education, where she lives, perhaps how heavy she is, whether she takes hormone replacement therapy, and whether she exercises regularly or not. So if we want to minimize breast cancer risk, we should have our daughters drop out of high school, get pregnant as teenagers, be poor, live in a rural community, be anorectic, never take hormones, and be exercise fanatics. But we laugh about that, and we laugh about that because most of those things are just not things that a young woman is reasonably going to modify because of a future concern about breast cancer. And because of the difficulty in modifying risk factors, there have been attempts at actually what we call breast cancer prevention or chemoprevention by using medications to try to minimize breast cancer. The first of these trials, and probably the best known, was performed by a large international cooperative group called the National Surgical Adjuvant Breast Project. And they initiated a prevention trial that enrolled women who were aged 35 years of age or older, who had no personal history of breast cancer, and by some computer-based models had an estimated risk of developing breast cancer in the next 5 years of greater than 1.66%. To put that in context, that's the risk of the average 60-year-old woman in the United States of developing breast cancer. And it was a huge trial, over 13,000 participants. This shows the data from this trial in terms of looking at cumulative likelihood of the women developing invasive breast cancer. 7 years of time is shown here. The women who took tamoxifen are shown in the blue line, and they had a lower likelihood of, or a decreased likelihood of developing breast cancer compared to the placebo-treated women who were shown in the yellow line. Now, the use of tamoxifen as a breast cancer preventive agent in the United States, though, is very uncommon. And it's very uncommon, and many physicians are reluctant to do it because while tamoxifen has acceptable toxicity as a cancer treatment agent where it is typically used, it has toxicity that is, in most people's book, not quite acceptable in a cohort of healthy women, most of whom will not develop breast cancer during their lifetime. There's a similar drug to tamoxifen called raloxifene that is also used as a preventive agent. Its toxicities are slightly less than tamoxifen. It is also slightly less effective in preventing the development of invasive and non-invasive breast cancer. So what about early detection? There are 3 major ways that we can think about early detection for breast cancer. One is self-breast examination, where the woman examines her breasts on a regular basis to try to detect breast cancer early. Another is what we call clinical breast examination. That's where a healthcare professional provides breast examination for a woman. And then breast imaging by mammography, ultrasound, MRI scanning, and potentially some other techniques. I'm going to talk only briefly about self-examination and clinical breast examination, and Dr. Aikita will be talking about methods of breast imaging itself. As we look at the studies that look at screening by any number of different techniques, as Dr. Barrick suggested, there are a number of methodological problems that we encounter as we approach these studies. And they make the interpretation of many of these studies extraordinarily difficult. The first is the so-called selection bias. If we just look at a study of women of who goes to their physician and gets mammography and who doesn't and how do they do, that study is flawed from the start because who goes to their physician is not random. The type of woman who goes to see her physician on a regular basis is a different type of woman than a woman who avoids doctors at all costs. And so the women who go to physicians regularly are not only going to have their mammography more often, and that's why we would look at them, but they're also going to have their blood pressure checked, they're going to have their pap smears more frequently, a whole variety of other things that are going to make them in general a healthier group of women. There also is what we call the length bias. So length bias means that if you do mammography on a regular basis over multiple different episodes, you will have a higher likelihood of detecting by mammography breast cancers that are slow growing. And you'll have a higher probability of detecting breast cancers that are slow growing because you'll have more opportunities over time to actually see it. One of the things that we often lose sight of is that if you look at a woman who has a newly diagnosed breast cancer by mammography, and she's had regular mammography in the past, often, and in some studies, the majority of the time, you can see the breast cancer before. You just didn't, the radiologist, for whatever reason, didn't recognize it, or the characteristics of that cancer did not exhibit the characteristics that we associate with malignancy. So in retrospect, we're really, really good. going forward were pretty good. And the length time bias, again, because the radiologist has multiple opportunities to see the abnormality. If you just look at who gets mammograms versus doesn't, it doesn't work, because you detect the favorable tumors more likely, and so the outcome of those women looks much more favorable as well. There's also the so-called lead time bias. Lead time bias relates to when you detect a disease over its natural history. So let's say we have identical twins who get breast cancer on the exact same day. Their breast cancers are identical, and their breast cancers are resistant to all treatment. One of the twins loves doctors, and so she goes to her doctor on a regular basis and gets a screening mammography when the tumor is really, really small and has the tumor diagnosed. Her twin hates doctors and doesn't go to see her doctor for several years along the way, let's say 5 years, until she is almost ready to die, and she has a huge tumor, and she doesn't need a mammogram to detect it. Well, I've already said that treatment didn't make a difference for this specific tumor that the twins had, and so both of the twins die on the first day, or on the same day. The twin who was diagnosed 5 years prior has a 5-year survival from her disease, because the survival starts with the date of diagnosis and goes to the date of death. The second twin only had her tumor diagnosed a week before she died, and so she had a 1 week survival. The screening made no difference in outcome, and the late diagnosis in this situation makes no difference in outcome, and that's what we call the lead time bias. Where you diagnose a tumor may or may not impact how well a woman does with that specific tumor. There are also concerns about overdiagnosis, and I think Dr. Akita will talk about this to some extent. And overdiagnosis means that if we look at screened populations by very sensitive techniques, modern techniques, we find that there are more cancers diagnosed than we would expect to see in that population. And that's probably because not all breast cancers are biologically important. Many, probably most, are that we detect by screening mammography, but almost certainly not all are. The difficulty we have today is we can't tell which ones are important, biologically important, and which ones are not biologically important. So we end up treating all of those women, and so to some extent we're almost certainly over-treating some women, even those women who ultimately we find truly had breast cancer. So pretty much all of these biases and methodologic problems that we have in these clinical trials can be overcome by what we as clinical trialists think are pretty straightforward methodologies, and they include randomization. So who gets the screening test versus who doesn't is determined by chance, not by whether a woman goes to her doctor or not. And we don't use survival as the endpoint, but we use mortality as the endpoint. How many women are dying in each individual in any given year? Not how long are the women living, but how many women in the groups are dying in any given year. And if you compulsively use those methodologies, most of these biases just sort of go away and are corrected for. So what about self-examination? There have been 2 major studies looking at breast self-examination. The best one of the studies was performed in Shanghai, and what they did was they identified textile factory workers in Shanghai, and they randomized the women to teach them how to do clinical breast self-examination and reinforce that on an ongoing basis versus not. And they randomized them by factory. This was an enormous study. There were over 250,000 women in this study. So the result is not a result that we're going to see by chance. This is a huge, huge study. And what they found was that if you look at the number of cancers that were detected in these women by the breast self-examination, which is shown in gold, or the non-breast self-examination factory shown in blue, identical numbers of tumors discovered in those populations of women. If we look at the biopsies, the women who did breast self-examination underwent many more biopsies because they found things that they were concerned about, called them to the attention of their healthcare providers, who confirmed the physical finding, and then the women had biopsies. So no difference in frequency of diagnosis, a substantial increase in the number of biopsies. So did it make a difference in outcome or survival? That's shown here, which looks at the cumulative numbers of women who died in this study. 11 to 12 years of follow-up, and the follow-up in this study is almost complete. So it's really high-quality data. And as you can see, there was no difference in mortality rates between those women who did regular breast self-examination versus not. The other study is a Russian study, and the Russian study also shows no difference in outcome between women who do or don't do regular breast self-examination. Looking at professional breast examination is really simple because there have been absolutely no studies performed of the value of doctors or nurse practitioners or other healthcare professionals performing routine physical examination of the breast. So most of you who are here are women. You go to your gynecologist or your primary care doctor once a year, and they do a clinical breast examination. We all do it. We all believe in it. There is no evidence that that provides you any health benefit. And with that, let me turn it over to Dr. Akita.
Thanks, Bob. Let me turn this on a sec. Okay. So that doesn't mean you're not supposed to go to your doctor every year. Okay, so now it's my pleasure to introduce Dr. Deborah Akita. And Dr. Akita is a professor of radiology at Stanford, is also the director of the breast screening program at Stanford and the Stanford Cancer Center. Thank you very much for speaking tonight.
Thanks. Thanks, Dr. Barrick, and thanks for inviting me. Now I know I have to go get my pap smear and exercise. I'll go to the gym after this. Not. So we're going to talk about screening for breast cancer. There's been quite a bit of controversy recently about recommendations about when to get mammograms. So we're going to talk about that. It has caused a lot of angst and controversy, talk at on the internet and also at the dining room table. I'm going to cover two things first: breast cancer screening with MRI, breast cancer screening with ultrasound, screening with mammography, how we do it at Stanford, and then recommendations from the United States Preventative Services Task Force, or the USPSTF, a bunch of letters, what their recommendations have been based on their analysis of the scientific evidence. And I'll go over that in just a couple minutes. First of all, breast cancer risk increases with age, and the probability of a woman developing breast cancer by age increases as she ages. At age 40, the risk is 1 in 69, age 50, 1 in 38, and age 60, 1 in 27. So as a woman ages, her risk of having breast cancer increases. That's the first thing. But as you saw from what Dr. Carlson said, breast cancer incidence has stabilized in recent years. And the breast cancer mortality, or deaths from having breast cancer, actually has decreased, probably due to many factors, including better treatment, but also probably due to screening mammography, that is cleaning out the early cancers so they don't grow up and kill you when you're older. Now, what's the evidence for mammography, MRI, and ultrasound screening? Well, first let's go to MRI, then ultrasound, and then mammography. Here's the first one. In 2007, MRI screening was recommended for women with a 20 to 25% lifetime risk of having breast cancer, or for women who had Hodgkin disease. Now, as you have heard from Dr. Carlson, if you have radiation to your chest, the breast gets scatter radiation, and you can have a higher incidence of having breast cancer. Right now, based on their analysis, there is insufficient evidence for or against screening for women who have just a personal history of breast cancer, atypia, or dense tissue on mammography. What is a high-risk woman? It is defined by a greater than 25 or 20% lifetime risk of having breast cancer. This will include those women with genetic mutations for breast cancer, strong family history with a certain family history pedigree for breast cancer, And these definitions fit most published series of screening breast MRI in high-risk women as defined by specific models, the Gale or the Klaus model. Now these models are questions that are asked of young women or of any woman about their breast cancer history in their families or other risk factors, both breast cancer and ovarian. These are the data that show that MRI screening in high-risk women find cancer. Now I'm just going to tell you, if you look at breast cancer screening with mammography in average risk women, the usual number of cancers you find with mammography is 6 to 8 per thousand. Okay, 6 to 8 per thousand the first time around. If you clean out all of those cancers and then you look at only incident cancers or new ones that develop since the prior year, those cancers will be 2 to 3 per thousand. Now if you look here, in these high-risk studies from 2000 to 2005, there are 4.6% cancers. That means in 100 women, there would be 4.6 cancers, versus in a normal screening population, 6 to 8 per thousand. So this is a very high number, and these are the data that indicated that breast cancer screening for very, very high-risk women, BRCA1, BRCA2 women, might be justified because you find breast cancer in those women. Now, how do you do it? Basically, the woman comes into the MRI suite. This thing is called a breast coil. It doesn't look coiled to me, but there's some holes in it, and you're supposed to put your breasts in it. They hang dependently. Put your arm down at your side, and they start an IV and put some dye inside your vein. And inside the vein, and I got to thank Dr. Daniel for this slide, notice that this is the anterior part of the breast, the chest wall is back here, and this is white stuff here is normal glandular tissue. Fat is black. We tell our women, you're not fat, but the breast does have fat inside of it. So the breast usually has fatty tissue, as you see here, and white glandular tissue. Now notice there are two areas here, and they're both white. When breast cancer occurs, the tumor will take contrast, which shows up white on the MRI, and make it look white early. And the tumor will light up early, as you see here. Let's pretend that this is how white the area is. It gets white really fast and then it starts to wash out. Whereas normal tissue will start enhancing or get white really slowly and then continue to get bright later on, but never as high as the breast cancer. And so that is what is so powerful about MRI, because it's not affected by dense breast tissue. This woman is a young 38-year-old woman who had a BRCA1 mutation. On mammography, it was hard to see through her breast. She had an MRI, and you can see this little white area here that is different than all the rest of the breast tissue. Chest wall's here, her liver's back here, the nipple would be there. Because this lit up early, we biopsied it. It was a very early form of ductal carcinoma in situ, or the earliest form of breast cancer when it's most treatable. The limitations of breast MRI are, unlike mammography, there's no mortality data, meaning we don't have that endpoint that Dr. Carlson talked about. We don't know if these women are dying of their breast cancers or if we're saving them. We're not going to know for years and years and years. And that's just the truth, but we have to go with what we know from the mammography mortality data. Number two, there are a lot of false positives. Now, what is a false positive? Well, this lady not only has her breast cancer here, but there's a little dot of something back there. It's white. It's whiter than the surrounding tissue. Now, in the old days, we'd be worried about that, and we might do a biopsy just to make sure there's not a second cancer. And so people have trouble in distinguishing those, and so there can be unnecessary biopsies. It's not really unnecessary, I got to say, because if you find something funny, you better biopsy it. It's just something that's not going to end up being cancer. There's limited access to MRI-guided biopsy here at Stanford. We helped develop this since 1992, so we have that availability. The last thing I want to warn you about is MRI sometimes cannot find the earliest kind of cancer, meaning the one that is found by mammography most often, ductal carcinoma in situ, the very, very early form. 25% of the time, MRI, even the best one in the world, is not going to find it. It's just a limitation of that technology. So often there may be suspicious calcium particles on the mammogram. Those calcium particles have to be biopsied because of this limitation of technology on MRI. That's now well known. How about breast cancer screening with breast ultrasound? Well, the most recent data is that from Dr. Berg, Wendy Berg in JAMA. In her study, she looked at 2,800 women. They screened them with mammography and by ultrasound, and they followed them up at 12 months. Well, how many cancers did they find? Well, for mammography, they found 7.6 per thousand cancers. When they added ultrasound, they found 11.8 cancers per thousand of the women. So when you did ultrasound in addition to mammography, you added between 1.1 and 7.2 cancers per thousand in this particular study. Well, everybody would say, well, boy, we ought to do it right now. Well, the problem that happened was they might have found a couple more cancers. But on ultrasound, number one, it has a hard time finding DCIS, which is that ductal carcinoma in situ, that is often only seen by calcium particles. And the reason is because they look like little speckles on the mammogram, and they look like speckles on the ultrasound, and the ultrasound has a bunch of speckles. So it's really hard to see it. It's like little stars in a starry night. Secondly, notice the positive predictive value. You want this number to be really high. That means that if you have 100 biopsies, if you have something suspicious on the mammogram, 22% of the time it's going to be cancer. If you add ultrasound, it starts dropping. 11% of the time it's going to be cancer. If you do ultrasound screening, less than 10% of the time it's going to be cancer. And so there are so many biopsies produced by the abnormal ultrasound that this physician, the lead physician, said that ultrasound may increase breast cancer detection, but it substantially increases the number of biopsies, so much so that it's not applicable to our population. And so it was not recommended to do breast cancer screening with ultrasound for this reason, and also because there's a lack of operators available in the United States and it's not standardized. So let's go on now to mammography. So MRI for high-risk women, ultrasound screening not recommended at this time. How do you do mammography screening? Well, basically you use X-rays to look through the breast for suspicious findings that you think might be cancer. This is how we do it. We compress the breast about 1 week after the menstrual period, or have our patients take Tylenol. We compress because we care. We have to compress so that we can see the small tumors inside the breast. This is the old analog screening mammogram. So there's film screen mammograms. You've heard about digital mammograms. Most people look at this and they say, where in the world did you get that wallpaper? I think it's nice. So anyway, a screening mammogram would put an X-ray film here, and then this would come down and compress because we care, and we'll be able to see the little tumor. Digital mammography, take a look at this machine first. Notice that the digital machine, this is when my hair was short, also has a compression device and looks exactly like the analog machine. Okay? It looks exactly like it, except it uses this computer to detect the findings on the mammogram. Okay? And then notice here, my short hair, previously we used to read X-rays on an alternator, and now that I have beautiful long hair, we now read it on monitors, and this is, we compare to the old regular X-rays that were on film. Now, how do we find cancer? Well, the normal breast is dense. That means it's white. It doesn't mean it's like a rock or anything, and when you feel it, it's not going to feel hard, but it's mostly made out of fibroglandular tissue that looks white. And as you age, that glandular tissue turns into fatty tissue. Okay? This is a normal mammogram. This is the upper and the lower part of the breast. These white things here, they're Cooper's ligaments. They form the honeycomb structure that holds the breast up. This is the normal nipple, and there's a little lymph node up here. Notice that the background is black. It's black because it's mostly made out of fat. This is an older woman because her normal dense tissue has turned fatty. Cancer is white. I want you to remember this. This is an older woman. It's easier to see cancer in the background. This is a woman who's about 48 to 55 years old. Okay? Notice that she has more glandular tissue. That is this white stuff. Looks like a little cloud, kind of like those, I don't know, cumulus cloud up here, and these are those little puffy clouds. I don't know what they're called. Anyway, it looks like a big cloud. And then a young woman, okay, this woman happens to have a pacemaker, hardly see through. Imagine you get a little white thing, a little white cancer on that background, you're not going to see it, because it's like a polar bear in a snowstorm. And it's not that I'm not looking for the cancer when I'm reading these. I'm not back there picking my nose or anything. I just can't see it. It's a limitation of this technology. Okay? What does cancer look like? Well, it looks like these things. Calcium particles are a little spiculated mass. And that's because when cancer starts growing inside these ducts, it can die. Parts of it will die and form little calcium particles. It has nothing to do with taking Tums or I have no stock in Tums or anything, but you know, it's just not, or taking your calcium, take your calcium pills. It has nothing to do with that. Okay? These just happen to form. And what I'm showing you here is glandular tissue, and these little white things is what I'm looking for, and those can be cancer. And that is the only thing that I'm going to see. So if I'm back there a long time reading your mammograms, because I'm looking for those. Notice that they're hard to see against the white background. Now, this is a looking down picture. This is the outer and the inner part of the breast. The nipple is here. Everybody can see the mass back here. That's an invasive ductal cancer. The lady was feeling her breast. She could feel a lump there, and she felt this. But actually, look, there's a second one here. And what you might not have seen is that it was there hiding. So some of them hide, and they're hard to see in the dense breast, and now you can see why. This lady felt something in her left breast. This is the right, and that's the left breast. I put these back to back. This is the pectoralis muscle. This is the nipple tip here on the left. That's on the right. Where's the tumor? Looking down, here it is. Okay? This was a side view with her head up in here. This is looking down with the outer part of the breast here and the inner part of the breast here put back to back. Notice this is whiter than that. That's a spiculated mass. Now you can see what the limitation of mammography is, and that's a technical limitation. But it's better with digital mammography than it is in analog mammography. So let's go to the controversy. There were 8 randomized controlled screening trials in the world of women invited to breast cancer screening with mammography. The analysis of those showed that breast cancer deaths was reduced by 30% in the women invited to screening. The effect was seen about 6 to 7 years after the initiation of screening. That makes sense, because remember I told you the first time around, 6 to 8 per thousand. Well, if they've got cancers growing at the same rate, then you clean them out, meaning they're gone, they're being treated. Little cancers start growing up. You treat those early. You're not going to see the effect until 6 to 7 years after invitation. So the effect was also seen in women 40 to 50 years old. I'm going to show you what the previous recommendations were based on this information. The previous recommendations was annual screening mammography for women 50 years and above, mammography 1 to 2 year intervals between 40 and 49 years old. And the American Cancer Society has not changed their guidelines. I'm going to tell you now what the controversy is. Back in November of 2009, the U.S. Preventive Services Task Force made a recommendation statement. What they did is they looked at a bunch of screening mammograms, same ones that the previous screening mammogram recommendations were, where they said to screen women 40 to 49 and 50 and above. Health Insurance Plan of America, the Canadian study, Gothenburg study, Stockholm study, Malmo mammographic screening study. I worked in that study for 6 months. Swedish 2-county trial, and finally the age trial. So they looked at this data. I'm going to tell you what they recommended, and this is the final recommendations. They recommended to not screen women 40 to 49. They said that because the effect of screening in breast cancer mortality was so small compared to the number of biopsies, that they would not recommend it now, and they would recommend somebody like Dr. Barrick or Dr. Carlson to talk to each woman and take their own context and values to decide whether or not they wanted to be screened. Okay, and I'll tell you why in a minute. So they're not going to recommend screening. They did recommend screening for women aged 50 to 74, but every other year instead of annually. They thought that the cost effectiveness would be best every other year. They recommended no recommendation. They had insufficient evidence for women age 75 or older because they didn't have enough evidence to know. That's because the randomized controlled screening trials were between age 40 to 75 at most. So they don't know what to do with women age 75. There's no evidence. Okay? There was no recommendation to do clinical breast exam, and they recommended against clinicians teaching breast self-exam. You've seen the data from Dr. Carlson on that. What does that mean? The summary now means that private insurers will usually cover those recommendations given by the USPSTF. So if we're going to follow those, since it's a grade C, they may not reimburse for women who are age 40, 49 for screening mammography. That's the way it is. What else is the recommendation? They may not cover annual screening mammography. Now this is for average risk women. We're not talking about BRCA1 or BRCA2 or women who have a very, very high risk. Okay? We're talking about your average woman like me in Safeway. I don't have any stock in Safeway either, sorry. Coverage for breast cancer, when it may not be required, might be just given every other year. And after age 74 years old, they may not cover it at all, okay? Because of those recommendations. Why? They thought, number one, that the 15% decrease in breast cancer mortality was not enough for those women 40 to 49 because of a couple of things. Number one, the dense breast, we miss more cancers in. And I showed you why. It's because it's denser. It's harder to see. The cancer's harder to see in there. But I'll give you some other information about that in a minute. Secondly, false positive studies, meaning we might see something funny and then we'll call the patient back. They're worried about the woman's anxiety from recall, and it is anxious, and then additional studies and the cost of those additional mammograms and studies. They're concerned about breast biopsies of things that are not cancer. And then they're worried about overdiagnosis, something Dr. Carlson talked about. Meaning, what if a woman, all of a sudden you have calcium particles and you do a biopsy and it's ductal carcinoma in situ? Well, we know from the twins that Dr. Carlson talked about, we might detect these a little bit earlier, but if we have no effect on their overall survival, then people would say, well, what does that matter? The problem with the question about overdiagnosis is that, let's say you have two women with identical looking tumors. They're small. You biopsy both of them. Patient A has a really bad one, and then you treat it and she does better. Patient B has a finding that if she never got screened at all, would never turn into something that's going to kill her. You get it? You got two ladies, and like one gets biopsied, and if she lived to be 105, it would never grow up to kill her. That's called overdiagnosis. Well, let me show you what I think about that. Number one, dense breast tissue for missed breast cancers. Our technology is different from the randomized controlled trials. Those trials were done in the 70s. I've seen them. I was in them into the 1980s. They were good studies. But now our technology is different. We have digital mammography, and it's better. We also have CAD or computer-aided detection. So things have changed a little bit. Second, are false positive studies really unnecessary? That's not true. They're necessary. There are so many people who have pain in their appendix area. They'll get an appendectomy, and it's normal. You have to do these things in order to find cancer early. Next, breast biopsies that are not cancer. Previously, these were all done with surgery, right? They were all done with surgery. There was no needle biopsy. And now we have minimal invasive procedures. Yes, it does cost money, but that's what we got to do to find early cancer. And overdiagnosis. Well, the problem I have with that is, how do we know which one of these cancers isn't going to kill the woman? If I do a screening mammogram and I see something funny, I don't want to ignore it and say, oh, it might be okay. I'm going to take a chance and I'm going to say, if I find that, I'm not going to treat it. Really what we need is some sort of test on those little cancers to figure out which are the bad ones, which are the ones that are going to kill the woman. And that may help us with this problem of overdiagnosis. Right now, we don't have the answer. So what's the data about digital mammography? Well, the Akron study in 2005 by Dr. Pisano showed a statistically significantly higher breast cancer detection in women who underwent digital mammography if they had dense breasts. If they're premenopausal, if they're age 40, 49 years old, or if they had heterogeneously dense or dense breast tissue. So digital mammography is helping us, okay? Secondly, how many biopsies are needed in the age group 40 to 49? This data is taken right from that recommendation statement. Notice if you're 40 to 49, in order to find one breast cancer, you do have to screen a lot of women. You have to screen 556 women. Some 47 women will end up having additional studies. And then if you have a biopsy, to find one case of breast cancer, you have to do 5 biopsies. So that's a 20% true positive biopsy rate, and that's acceptable in the United States. You'll notice that these numbers go down as women age because the incidence of breast cancer is increasing. What are the absolute numbers of risk of breast cancer death? Why are we ignoring the women 40 to 49? Well, this information is from the meta-analysis of the Swedish breast cancer trials and the health insurance trial of New York and the Canadian trial. But what you'll see in total is that if you're on this side of this line here, it favors screening. The most recent study using women who are 40 to 49 is a study called by Moss et al., or the age trial. And what we see here is a 15% decrease in breast cancer mortality. What's the last thing that you need to know about randomized controlled screening trials? When we do a randomized controlled screening trial, you invite women to screening, and the other group is the control group. In the mammographic screening trial in which I worked, women were randomized to mammography screening by town. So if you were in Atherton, you go to screening. If you were in Menlo Park, you wouldn't go to screening. And if you were in Los Altos, you'd go to screening. If you were in Mountain View, you wouldn't go to screening. So they randomized them like that, okay, down the peninsula. If you got screened, the screening group includes those women who actually underwent the mammograms and those who were non-attenders, meaning people who didn't want to get screened. The control group included women who had no mammography and women who also underwent mammography because they said, boy, just because I live in, Menlo Park, doesn't mean that I don't want to get screened. I'm just going to go do it myself. And so that's called contamination. And there's always those problems during a randomized controlled screening trial. So the actual benefit may be different than what we're seeing in the mortality data because of those who didn't get screened and those who had mammography on their own in contamination. So these were the recommendations by the clinical summary for the USP-STF. Why am I going to continue to recommend the American Cancer Society guidelines? Well, the reason is because the randomized controlled population trial data has not changed. It's just the way that we've looked at it. Secondly, the new data from the age trial showed that there was a decrease in breast cancer mortality in the women 40 to 49 of about 15%. Third, the data that was analyzed, and there's nothing wrong with this, but the data that was analyzed cannot possibly take into account the advances that we have in technology, meaning the digital mammography and the core biopsy techniques that we have. Women do need to know that there can be false positives. When they get a mammogram, it's possible that they're going to find something that either may not kill them, even though it's cancer during their lifetime, or that there may be a finding that we might think is cancer and they'll have to have a biopsy. Women can make a choice. And I'm going to continue to recommend these guidelines. Thank you.
So, take a seat. Thank you, Deb. That was excellent. So I think we've set the stage for questions, and I think just to make it very clear, what Dr. Akita is saying bluntly is that the new recommendations based on the same data reinterpreted are not recommendation that she's comfortable with for all the reasons that she gave you. Bob, do you want to comment on that?
Well, I think that this is a situation where reasonable people can look at the same data and have different takes on it. And the 15% mortality reduction that's seen in the young women who undergo the, screening in the screening studies is a 15% reduction from an already quite low risk relative to the older women, because the older women have a higher frequency of breast cancer, so they have a higher mortality from breast cancer. And so 15% reduction in the younger cohort of women is less than 50% in an absolute sense of the 30% reduction that's seen in the older women, because they're relative risk reductions, not absolute numbers. I recognize that, and I actually end up, despite that, agreeing with Dr. Akita that the risk of the 15% reduction in breast cancer mortality with the incidence rates we have in the United States is still meaningful. And so I agree, and it's what I recommend in my own practice. But we shouldn't delude ourselves that if I were in a governmental bureaucracy where resources were truly limited, you are going to save more lives by screening only the older women preferentially than screening younger women preferentially. But I think in our society, you know, we at this point in time have the resources where we don't have to choose yet. We can really screen both groups of women.
Yeah, and the problem still is that a significant proportion of women don't get screened at all, even for breast cancer. So it's an issue of trying to more widely apply the screening tools that we have. I think, go ahead.
Yeah, I just say one of the other issues here is there are lots of types of contamination. And one of the types of contamination also is that if you have a blanket policy that women 40 to 49 should not be screened, it becomes much, much more difficult to convince an insurance company that yes, that's true for the average woman, but because of this woman's risk factors, we should screen her, because it's a barrier you have to jump over, it's authorizations you have to go through, additional letters that the woman has to write to her insurance company, and 20 minutes on hold with the insurance company's authorization person to make the argument. And so it's a contaminating influence that makes it even more difficult to get screening for the women who are absolutely going to benefit.
Yeah, it's hard when you put it back on the physician to just make an individual decision ad hoc when patients come in, because you don't know really all the risk factors. And a family history may not be thorough, or the patient may not be able to give you all the information. So it's difficult to ascertain. So blanket rules are easier to follow. One of the things that I wanted to bring up is this recommendation change for the biennial screen from age 50 to 74, that is every other year in simple English. And that, I'm concerned about that because of the number of patients I've seen over the years where you do a screening mammogram and it's normal, and then there's maybe one little thing and you, well, okay, come back in 6 or 9 months, patient comes back in 6 or 9 months and there's a full-blown cancer. And so you worry that waiting 2 years, you're going to miss a certain number. And I'm not sure that even in the retrospective studies, in a meta-analysis, you can capture that. Any comments?
I think it's hard. First of all, I don't think this is over. I think that we're dealing with limited resources, and I think that some facilities will adopt the policy of not screening women 40-49, and between age 50 and 75, every other year screening. There are studies, though, that show that if you have women who have yearly screening versus women who have every 3-year screening. If you look at the every 3-year screening, the number of cancers in that group and the stage, meaning how advanced they are, starts to approach a control group. Meaning if you never get screened, then you have a whole number of cancers at different stages, meaning a higher stage. If you screen every 2 years versus every 3 years, you start seeing more higher stage cancers. Why? One of the reasons is because some of the cancers may be very aggressive, and you might only have one chance to see it in 1 year, and then it'll get big and you're not going to feel it. Those could be interval cancers. The second reason is that if we have a chance to look, you just keep looking, then you're more likely going to find cancer. And then the other thing is, I'm going to forget. If you're supposed to get every other year, I'm going to say, yeah, I did it last year, and then all of a sudden I didn't get my pap smear for 3 years. Just something like that. I mean, people forget. So we want to make it easy.
I think the important point to stress, which has come up in every talk, is that there's no such thing as one kind of breast cancer or one kind of ovarian cancer or cervical cancer. That there's a great deal of variability in the rate of growth of cancers that has to do with the different types of cancers there are, and they grow at different rates in different people because every person is different. And some people may have a certain type of tumor that grows much more quickly in them than it might in another person. And then there are other types of tumors that we know, based on the biology and the genetics of that tumor, are more likely to grow quickly, and others that grow slowly, so-called indolent cancers. I think it's a very important concept, and it's one that both our speakers alluded to, because it confounds all of our research and studies and recommendations about screening for cancer in general. Do any of you have any questions that you'd like to bring up? If it's easy enough for you, can you step to the microphone and ask it? There's one right next to you, just so we can record it and hear it.
I would like to know if there are known long-term effects of hormone replacement therapy after the person has stopped taking it, say, a number of years, 5, 9, 10 years.
It's too bad that Marcia Stefanik isn't here. I think the short version is that many of the adverse health consequences that we've learned about in terms of hormone replacement therapy, increased rates of breast cancer, surprisingly increased rates of heart disease, and those endometrial cancer in some situations, typically are things that tend to go away pretty promptly after the woman stops taking hormone replacement. They don't the rates don't disappear, but they do trend back towards women who have not taken hormone replacement therapy at all very rapidly. And I think that's why we've seen decreasing incidence of breast cancer recently. We started to see increased incidence of breast cancers in postmenopausal women within only about 6 months of the publication of the studies that raised the health concerns, and so we rapidly saw the drop in hormone replacement therapy prescriptions. Within 6 months, we saw declines in breast cancer.
I should point out that there has been a huge paradigm shift in the way gynecologists treat patients with so-called hormone replacement therapy, with usually estrogen and sometimes in combination with progesterone. And it used to be that gynecologists would recommend giving it continuously after the menopause. And then as more and more data came out about the adverse consequences, particularly related to the increased risk of breast cancer, it's gradually cut back, initially to, quote, no more than 5 years. And now most people recommend the use of hormones for the most limited time necessary, if they are necessary, to help people through the menopause itself, which often is 6 months or a year, and then to go off of them again. So that the exposure of hormone therapy is a very short interval compared to what it used to be as a routine. So there's a substantial decrease in the use of peri- and postmenopausal hormone replacement therapy.
Dr. Akita, I know you like mammograms yearly. What is your take on blood marker tests for breast cancer, screening for breast cancer after an 8-year survival rate?
I wish we had one.
Do you,
We
do
thought
you
we found-
recommend blood marker tests or not?
So you're talking about in follow-up of women who've
In
had breast
follow-up
cancer?
treatment?
Let me take that one because I get asked that question all the time in my practice. So there are two markers that are putative markers that are available. They're the CA 19.9 and CA 27.29. I'm not sure I have that first one. It's CA 15.3. 15.3 and 27.29. And they measure proteins that are released into the circulation by some breast cancers. Professional societies have looked at the data from a number of trials that have looked at the value of those markers. And one place where essentially all of the professional societies agree is that those markers should not be performed because of the frequency of false positives and the frequency of false negatives. You can diagnose on average a recurrence of a woman's breast cancer about 2 to 3 months earlier on average if you do the tests, but no one has ever demonstrated that that makes any difference in the woman's outcome.
Thank you.
We have a similar situation with the CA-125, which, as you know, is a common test that's employed in women who have ovarian cancer. It's very useful in women who have a diagnosis of ovarian cancer and you're monitoring the course of treatment while on chemotherapy or for relapse. We do follow women with serial CA-125 measurements after they've gone into a, quote, clinical remission after chemotherapy. The problem is that it's used widely or misused wisely in women who are asymptomatic and who don't have a diagnosis of ovarian cancer, and there are a lot of false positives. So people are unnecessarily frightened and in some cases have surgery that turns out in retrospect to be unnecessary. So we have to wait for further study on that particular marker. I think we had a question over here, if you could step up to the microphone.
So I feel like I must be misunderstanding the new recommendations because obviously there's no controversy that women under 50 get breast cancer, and it's aggressive. It can be aggressive and it can be deadly. And what I understand from the new recommendations is that we shouldn't do self-exams, our clinicians shouldn't examine us, and we also shouldn't have scans. So how in the world would anyone under 50 that is going to get breast cancer ever be diagnosed unless their cat jumps on their chest?
CAT scan? Just kidding. I recommend screening mammography from age 40 to 50 yearly.
Yeah, I know you do,
Yeah.
but I'm talking about the
That's
recommendation.
why we're fighting it in the Society of Breast Imaging. There's a lot of, it's not over.
So my understanding is
over.
correct. It's insane.
Well,
They're analyzing the data differently, and we have a different opinion of that. It's not over.
I'm not so sure it's insane. Yeah. I think it's a situation, again, where reasonable people can disagree. And a lot of it has to do with value systems and how much someone is willing to go through to attain any certain goal. Anything we do in life is a trade-off of time. I personally know that if I go out and run marathons and exercise, that I will live longer. And I will live longer by about the amount of time I would exercise. I don't like to exercise. and so I actually make a relatively conscious trade-off that I don't run marathons because the time that I would add is not necessarily time that I would find enjoyable. And so there's a trade-off there that I make. And in many situations like this, there are trade-offs in terms of resources, trade-offs in terms of, a woman has to take half a day to drive to the mammography department and get the film done and then be anxious at home until her doctor calls her back, and so she's going to have some lost productivity. And how much is that worth to the individual woman? And that's why the service recommendations don't say that mammography should not be done. What they say is it should not routinely be done, and that the considerations include the woman's own philosophy of life. And so they're saying that you need to try to make those trade-offs in that group of women because the benefits, while they are real, on average are quite small.
But you put your finger on the controversy, and why people are so upset about it is because they look at it from precisely the standpoint you look at it, which is, wait a minute, what about us women in the 40s? We get cancer and we're not getting screened. And I think, as you point out, there's a question of how they've interpreted the data. I think if you look at polls of women now since this controversy has come up, the majority of women still in their 40s want to be screened. I mean, the latest poll was something like 70 or 80% of women polled said, I still want my mammogram or my CAT scan or dog scan or whatever. I want to get it done. And a similar poll of physicians was kind of 50-50. Which I found very interesting. But I think the big issue is whether or not this is going to have a negative impact on the payment for mammography for people who want to have it. I think that's an issue that's unresolved. And so far, there's push for legislation to require that it be paid when it's ordered by a physician, period. So. And I think that's true in California now, is it not? Am I correct?
I'm not sure.
I don't think it's legislated.
Not legislated. I guess there's a proposal that's been discussed.
Well, I heard at the Breast Cancer Connections meeting the other day that you're seeing more women coming in asking for support for screening mammography because it's being declined. Did I hear that correctly? Yeah. So in our community, outside the setting of patients with breast cancer that I see, we're seeing some of that happening.
Yeah. So that's a huge concern, obviously, if people want to be screened and can't get reimbursed through their insurance.
I have women coming in. I remember right after these recommendations came in, a woman came into our clinic and said, I have my order from my doctor, but can I still get my mammogram? So it's caused much confusion in the community. Can I still get it, or am I allowed? And so it's been confusing.
Following the new recommendations, they are kind of sacrificing early detection in low-risk women under age 50, and that's just something that they feel comfortable with because of resources or cost effectiveness. Yeah, I mean.
Well, I mean, if the more recent study using, if you will, more advanced technology shows a 15% reduction in mortality in that age group, obviously one group would look at that and say, wow, that's a 15% reduction in mortality. I mean, it's a pure number which you can interpret, as you want. And I think there are value judgments, and it's a controversial issue, and it's going to remain controversial. It's entirely possible that this series of recommendations would not be widely adopted. I mean, a lot of the professional organizations have kept with the other recommendation. I know the American College of Obstetricians and Gynecologists have stuck with the older recommendation that predated the one in November. And a number of the professional societies, what is the American Cancer Society current recommendation?
It's yearly.
Yearly, still. So because there are people coming down on both sides of this, it hopefully will not lead to any rapid change while there's further analyses and interpretation and study, which is what it takes, is more study.
So let me put a little bit more context around this, because the concept between relative and absolute risk reduction is a really difficult concept. So the average 40-year-old woman in the United States probably has a 5-year risk of developing breast cancer of about 0.5%. So that's about 1% per year, or I'm sorry, 0.1% per year. In the United States, about 70% of women who develop breast cancer do not die of breast cancer. So that takes that 0.1% risk of developing breast cancer down to a mortality risk just overall of about 0.03%. So that's like 3 in 10,000. Help me, guys. So 3 in 10,000.
But that's 70%
And so you're going to take that 3 in 10,000 and decrease it by 15% of that 3. So you're going to get it to about, what, 2.6, 2.7 out of 3,000 people. And so the task force says, we believe this 15% reduction. Despite that, it's not worth it. Because it's such, when you actually sit down and do the mathematics for what the absolute benefit to our society is, it's very, very small. Now,
Is someone doing the math for colon cancer?
The same issue exists in colon cancer, and the same issues in spades exist in prostate cancer screening, where the evidence is that prostate cancer screening doesn't work. It's an even bigger quagmire there. So it's not limited to young women with concerns for developing breast cancer. It's colorectal cancer, it's prostate cancer, it's screening for lung cancer. It's across the board.
And I think we have time for one more question.
Well, this is not actually a question. I just wanted to put a face to a hypothetical situation we were all discussing, and to support your views on the question on this issue, because I was 44 when I was diagnosed, and had it not been to annual screening, annual mammogram, routine mammograms, I don't think I would be standing here today. I had no risk factors, none of them, not a single one. And so according to these new guidelines, I would have not been screened, or at least recommended for screening, until age of 50. And my cancer would have, I would probably be dead by then. So only by chance, by routine mammogram that I religiously did every year, I was diagnosed, and my cancer was 2 centimeters, and I don't think that waiting another 6 years would do me any good, benefited. So it's just those are statistics, and here I am, and I just wanted to make sure this is on record.
Thank you. I think it's absolutely true. The minute we start talking about individual people and put a face on it, it makes this very, very critical that we study it more, we study it better, particularly as we have newer and better technologies. I suspect over the coming years, the phrase that Dr. Akita says is, "This not over yet," and I think that that's absolutely true. Optimistically, in a few years, we'll have another one of these. We'll have more data, and we'll be able to extend the discussion. It's my hope that we don't have too many delimitations on resources while this is being sorted out. I think that's probably one of the critical issues. Well, thank you all very much for attending tonight. We enjoyed having you here. Have a good evening.
For more, please visit us at stanford.edu.